Thank you for the chance. I'm Dr. AlMakadma, and I'm presenting from Riyadh at the moment. I'm a consultant cardiologist in echocardiography, and I'm honored to have the chance to speak to you today. The topic, masses, vegetations, or artifact, is a rather important topic that relies heavily on recognition, but there are a few important points and caveats that can be presented, and I believe again and again to make sure the correct diagnosis and management is done. I have no conflict of interest, and all references are noted in each slide with a few of my own collections. This review article is one that I believe a lot of Echo Fellows have seen before. If you haven't, I found it to be very helpful for myself. And I will use it heavily in the presentation along with the guidelines. The objectives of this presentation are to evaluate in a systemic manner the intracardiac masses. And the most common modality we use is 2D, and we use it for location, attachment, mobility, and echogenicity as the guidelines teach us to do so. But there are also applications of advanced echo modalities such as 3D and contrast, as well as transesophageal echo in accordance with the guidelines that are becoming more and more readily available. Recognizing common echo artifacts, not all of artifacts will mimic masses, but some of them do. And I hope that I'll help elucidate that a little bit. One of my secondary objectives is practice. Repetition makes perfect. And there are always small variations case to case, and there's really no dull day in the echo lab. The importance of why we're doing this is while multimodality imaging exists and echo remains a robust, fast, real-time, readily available and deliverable modality that can determine or even prevent treatment, such as in the case, for example, of a cardiogenic shock, cardioversion shock. When someone has a thrombus, you can prevent a treatment that could otherwise have sequelae. Remember that we scan for an answer and we call it echo laboratory. It's not an imaging center, it's a lab. So each patient has a question, a clinical question that we scan for an answer. So we will move and translate that probe to make sure that we, for example, get the extent and the full definition of a mass or a thrombus. The context of the echo being done, as well as other echo findings. So knowing the patient and their clinical history for any imaging modality is important, and on the bedside is also important. In addition to the findings in that study will help you define, such as an aneurysm in the LV will help you go towards, okay, I may have stasis and may have a predisposition to a thrombus. Artifacts can be a nuisance in the sense that they can provoke anxiety to patient and clinician, but making sure that we don't miss hard events is also important. This is a table I remember reading from Practical Cardiovascular Medicine, the textbook by Elias. I divided it into 4 parts based on the features, characteristics of artifacts, thrombi, and masses. And it elucidates how by anatomy and location you can think of artifacts or variants. Variants are not necessarily physics artifacts like reverberation or mirror artifacts, which we're going to get to in a little bit of detail. But you can also have anatomic variants and embryonic remnants that are not pathologic, although they are echo masses, but they don't need further treatment, such as eustachian valve, Chiari network, and crista terminalis. And this is an example of repetition makes perfect. So that can occur in the right atrium. If you're looking into the left atrium, a calcified aortic valve projecting inside the LA may actually be a physics artifact. So it would be a beam width artifact. An aortic valve, the nodules of Arantius, as you know, the thickening at the central tips of the aortic valve at the coaptation site, they can become more prominent as we age, and that can be not a cause for anxiety. Lambella's excrescences also exist. There's a little bit of controversy on whether they are embolic, there's an embolic potential or not. Mitral valve location, a thick myxomatous valve with elongated chordae. Will this need treatment or not? Is it a mass or not? Is it a vegetation or not? That would also depend on the context and on the advent of a worsening or new regurgitation and the degree of that, as well as flail chords. They are cause for worry, but they are not vegetations or masses. Rather, they're a normal structure that has had a rupture and then abnormal movement. In the right ventricular position, a moderator band is obviously a variant that's considered normal. An interatrial septum, that dumbbell-shaped looking septum that spares the fossa ovalis, can be lipomatous hypertrophy, which does not necessarily need any treatment. The second set of features are the features favoring cardiac thrombi. And I put a few of my own patients here. Someone who has a state of low flow in the left atrium and some sludge in there. That means that there's a potential that there may be a thrombus in the LA cavity itself. So making sure we sweep the full cavity on a transesophageal echo in this modality is important. Looking at these are also left atrial thrombi. So we look at the position. So most commonly in the LA, it's the LA appendage, but you can also have in the left atrium itself, depending on the predisposing factors that can affect the development of thrombus. And I remind you of the Virchow's triad. So in the LV position, look for apical akinesis. For a prosthetic valve position, look for valvular dysfunction, look for gradients, look for the turbulence in the color. Right-sided structures, look for foreign bodies, pacemakers, leads, and indwelling catheters. In case of venous thrombosis, you can also have a transition of a thrombus in situ or an embolus in situ that can also be seen. So this is just a refresher on stasis, vessel wall injury, or of course, foreign bodies and hypercoagulability that can lead to thrombi. The third set of features are those that favor vegetation, and they would originate from a valve, usually a free edge of the valve, and on the lower pressure upstream side, such as LA in a mitral endocarditis or LV in aortic endocarditis, may rarely come off the cords or the LA wall or underlying MR if there is. So the advent of a new MR or worsening thereof is incredibly important to signify in the study. Significant valvular regurgitation, therefore, also requires us to look at previous studies should they exist and compare. Abnormal valvular structures, abnormal baseline structure, valvular perforations, distortions, and obviously want to look for communications and abscesses. The irregularity of the shape, that shaggy, highly mobile, irregular shape, chaotic motion, goes more with vegetation, and it does not track with leaflet motion. But in real clinical practice, we can have questions arise. Is this a flail cord or is it a vegetation? This is a highly mobile structure. It obviously has its own motion, but there is a motion that's also related to the valvular motion. So there is an outward, inward, flutter, outward, and then again, inward, flutter, outward, inward, flutter. So do you consider this a vegetation or a flail cord, for example? And this is important. This was an orthopedic surgeon colleague of ours who went on to perform surgery and had a mitral valve repair. She did not have endocarditis. This is a young 15-year-old man who had a low immunity state and had vegetation. But interestingly here, without knowing the clinical context, you can see the upstream vegetation on the aortic valve, but it does not seem to be coming off the tips. It's not highly mobile, although it is mobile, but it is tracking with wall motion. So what I'm trying to illustrate here is that clinical context is very important, and it usually helps us achieve the correct diagnosis. But also you might need further imaging modalities. And I'll give an approach in a couple of slides on how to not miss heart events. The fourth set of features are those that favor cardiac tumors. So a myxoma, fibroelastoma are the common ones in the adults. The adult age where I practice starts at the age 14, so we also see some rhabdomyomas. We have all probably been tested before on the epidemiology of the different cardiac masses by age group, and that is something to keep in mind. So myxoma is the most common in adult population and originates from the interatrial septum. It's more likely to be on the LA. This is an incidental finding we had in an 83-year-old man who was admitted to the general ward for pulmonary infection. They did the echo just because he was desatting. They were not sure if he had heart failure, even though he didn't have any stigmata of heart failure. So I maintain that this is an incidental finding, but it turned out to be a myxoma. Knowing the clinical context is also important, and that's why echo, again, it's a laboratory, not just an imaging center, and it is for the clinician, so we have to have a robust thinking mind. This was an even younger patient, 14-year-old, who had an AVRT, an ablation to a posterior pathway, and you can see on the posterior septal aspect, there's a hyperechoic mass, and that was related to the ablation site and the edema. The other patient is a 48-year-old man who had severe rheumatic mitral stenosis. And knowing the other findings in this echo makes it easier for me to rule in rheumatic aortic nodule rather than anything else at the aortic position as well. So we had multivalvular involvement. So when we talk about masses, the simplest way to divide them is thrombus and not a thrombus. But then when it comes to the non-thrombotic masses, you're going to look at primary cardiac tumors and at secondary metastasis, and the primary would be divided into malignant and benign. Luckily, the benign ones are more common, and the tumors in general are rare in the heart, but they do remain an important component of cardio-oncology practice. And benign tumors are more common than the malignant ones in the cardiac tumors, and maybe metastatic tumors are also common. And so looking for the full idea is also, the full patient picture is also important. And identifying common features that are such as that consistent with a myxoma, having those like grape clusters and stalk and clear edges rather, or looking at Lamb excrescences, which would be downstream from a valve and they're like threads, or looking at a fibroelastoma, and I'll show some examples. Now, this slide is from the College of Cardiology, Cardio-Oncology, and I also think this picture we have had hung up in our echo lab. And I think this should be a memory item that, the different chambers can have thrombi depending on the state of stasis in foreign bodies, but they can also have myxomas, more commonly in the atrial positions and more so in the left atrium coming from the septum, of the interatrial septum. But then it's also important not to miss intramural masses. So it's always flashy and nice to look at masses that protrude into a cavity, but intramural masses and pericardial masses are also important to be seen. So cardiac masses are either structural, such as Chiari networks, or crista terminalis, a vegetation that can be infective and non-infective, of course, and thrombotic, especially when there are stasis or foreign bodies and tumors, which can be metastatic or non-metastatic, and for the none, they can be malignant or benign. And there's also the epidemiology breakdown for adult and pediatrics. So this is nice as a reference slide. Knowing the anatomy of things like embryonic reference, there's an article that's nice to look at. This is an EP procedure. They were going in the interseptal puncture, and they pushed the Chiari network into the LA. Also, I'll show a couple more pictures here. So you see the railroading appearance of a catheter, and as it traverses the interatrial septum and the Chiari network are pushed in. Should the operator be sure of what they're looking at and that there's no risk of embolism, they can continue to conclude their procedure without having to abort. So it's important to be oriented. This reaches almost the half point of the presentation. So there's an important idea to allude to or to allude to here, which is understanding the location, attachment, mobility, and echogenicity. These are the four things that are clearly mentioned in the guidelines. But I also like to add, know your basic views, trust your landmarks, and look for them when interpreting, and interpret in context. And also the recent recommendation that was published in 2025 on reporting echoes by the ASC is something that I highly recommend. State clear, simple terminology. Make it very easy for the clinician that's the most responsible physician to take the next action based on a clear message. I'll give you an example of where lack of clarity can cause a mess. I received this unidentified image precisely as so, and I was asked by the surgeon, can this mass cause a thrombosis, an embolus into the left main? Now, this is the pulmonary valve, not the tricuspid, and this is a TEE, not a transthoracic. And they're looking at the non-coronary cusp, not the left coronary cusp. It's just the view is actually facing 144 degrees, and it's a mirror image. And this would be the line of the imaging. And so the interpretation was not the most accurate. When we looked at the full study, of course, this is what the surgeon was afraid of. He was afraid that they're looking at, rather than a low risk PFO flap here, they thought they were looking at the left main. And so this is the same patient, and you can see this is a simple transthoracic echo repeat that I did in my clinic bedside, and it elucidates the anatomy. And then this is the 3D image and you can see the interatrial septum there. So context is important. And just as a side caveat, this is a nice article about papillary fibroelastoma, that they are potentially an inflammatory post-microthrombotic event that then causes this fibroelastic change. And the fear is always that these masses may embolize. And what do? Do you remove them, and do you keep them? And there's a role for shared decision-making with the patient. When it comes to vegetation, remember that they're an oscillating intracardiac mass on a valve or other endocardial structure. They're usually highly mobile, and they have independent mobility. The classic features that they're located upstream, but always interpret in context. Because any abnormality to the normal structure can change the flow and pressure state of the hemodynamics, and therefore can also change the location of vegetation. We have seen vegetations, for example, on the cords of the mitral valve. And so having a systemic approach is important. And this is the thing that I would recommend also keeping in mind. Look at the location, the attachment, mobility, and echogenicity, and keep in mind a framework that would determine for each one of these four. If it's a vegetation, the classic location would be on the upstream side, on the lead, on the foreign body. If it's a thrombus, on the other hand, it might be in the mural area, especially when there is stasis and aneurysm and akinesis. And so you'd want to look at the apices, look at indents into the myocardium and appendages. So you want to look at things like non-compaction. You want to look at, in addition to, of course, the regional wall motions mentioned. If it's a tumor, you want to look at the interatrial septum. Of course, you will have to evaluate depending on where you see the mass, but then you want to try to see where it's attached and where it's coming from. And if it's an artifact, the artifact can be anywhere, so you want to try to identify what the artifact is so that you're sure you're not missing something. To me, I always try to get multiple images from multiple views, and I would ask for help after doing the usual change of harmonics and potentially even moving the machine itself, especially in intraoperative settings, if I think that there is an electrical interference or electromagnetic interference of that nature. So the attachment would also help you with the vegetation. It's pedunculated, a narrow base, a broad base, maybe a thrombus. Again, the tumor would be pedunculated, but then the shape would be different. And if it's an artifact, that you wouldn't necessarily have a true attachment. It might be floating, it might be fixed, and it might be moving with the myocardium, but in the wrong anatomy. The mobility would be highly independent for the vegetation, but would not necessarily be so for the thrombus, tumor, and artifact. If a thrombus is highly mobile, then that's a high-risk thrombus for embolic events. And that's something that needs to be kept in mind. For the echo density or echogenicity, you can have variabilities actually depending on which chamber you have your mass, especially when it comes to thrombi. So you want to look for a relatively hyperechoic mass in an LA appendage, for example, where it should be a translucent area. And you may want to see you may see something that is slightly hypoechoic in an area where it should be, for example, in the area of the LV apex, you might have a hypoechoic comparison to a fibrosed apex that's thin and already akinetic. But then also you have variability depending on whether it's fresh or old. The fresh would be more echolucent. The old, more organized thrombus would also be slightly more dense. So artifacts are not real structures. They're not real structures where they appear. They may be real structures, but they're appearing as a mirror or as a projection elsewhere, whether due to reflection or refraction or to harmonic resonance, which would give that equidistant appearance of an artifact. So anatomy might be wrong, the anatomy location, the brightness or the color may be wrong, the basic physics principles. The basic physics principles, they're always stable, they're always the same. The idea is what the physics is doing is real. It's actually interpreting reflected sounds. But because of, for example, you may have an issue with calibration, or you may have a highly reflective object, such as a pleura or a pericardium or a calcified nodule or a foreign body, such as a metallic body, for example, that can also give artifacts. So artifacts can cause concern, and it is important to be able to recognize if whatever tools you have, you try to always look for the distance, you look for adjacent processes, you look for calcifications, such as in this case. So let's talk about the types of artifacts. This is a beautiful article as well. Dr. Serish is a famous one. He's been doing the reviews for the echo boards. I absolutely like this article. I think the artifacts made more sense to me once I looked into it. And so you can take artifacts located below the real structure in an axial depth or in lateral direction. And that's a very simple way to start your approach. If it's a reverberation, a mirror, or acoustic shadowing, it's usually along the depth direction of the transducer. And a beam width artifact or side lobe artifact, they can be slightly beside the main beam and the focal point. The approach to artifact would be, you can change your views, you can change your harmonics. For example, on the Philips machine, you can change your penetrance. And then on the different machines, you have your harmonic settings. And you're on the bedside, change them and see what happens. Change the depth and use color if you haven't, and use multiple views. But be careful of things like using multi-view, because the probe is in the same area and it's transmitting the same waves. And you may also want to move the machine or even use a different modality if in doubt. But take your time and maybe ask. This is I've had a patient referred with a similar image. This is not mine, the reference is here, but I was referred for aortic dissection, and it was actually a reverb from the pulmonary artery. And so it is also important to be aware of what, and the interesting thing is that here you can see the pulmonary artery visible, but in the study that was referred to us, it was not all that visible. We only could see the shadow, and I wonder why that was. Sound waves bounce between two strong reflective surfaces, creating a series of equally spaced parallel echoes that are misinterpreted as real structures. The interesting thing is that you can also look at the mobility, at the color flow through it, and you can see that it is not necessarily related to the mobility of the aorta. But then these are not contractile structure by nature, they're only pulsatile. And so it does create a little bit of a difficulty if you don't have a full study. When it comes to reverberation artifacts, so the assumption is that the image is reflected once, but what actually happens that you get an image that's also reflected from a structure twice as deep of the real structure. And this can be seen here. So you can see the Q-tip, for example, in an LA appendage imaging, and you can see an artifact that is something that clearly should not be there. The side lobe artifacts are artifacts that would be slightly fuzzy in nature. They would come slightly to the side, and they can also look like structures. So of the aortic valve, for example, if it's not centered and it's coming slightly to the side of the sector width, you can have side lobe artifacts that may mimic Lambel excrescences or even linear structures that can make us think of other pathology. So that's an example right here of a side lobe artifact. And the assumption is that you can see the focal point here is actually the area from which you angulate your reflection. And it's always nice to be able to think where my focal point is. Now, some machines still have the focus showing on it, and other machines no longer do. They claim the pan focus technology, but we still see those artifacts. So it makes me wonder how much of this technology is just post-processing. For beam width artifacts, they will violate that the echo generated only from reflectors located within the main ultrasound beam. In this case, you can have objects that are far reflected onto proximal areas closer to the focal zone, and it would also confound interpretation. I don't have an example for beam width artifact, but I will say for artifacts and variants such as the anatomic ones, stop, correlate clinically, call the doctor who requested the image if you need data, or open the chart, consult references if you have them. But my go-to, in addition to opening the chart and reviewing the patient or even talking to the patient, is also consulting with colleagues. So I will summarize in a slightly different way. Let's look at the morphology, if it's shaggy, smooth, or round-like. Let's look at the mobility. Is it chaotic or fixed? So these are vegetations, for example. Do they move with structure? No matter how fast the mobility is, always ask yourself, does it move with a structure or does it not? Look at the mechanics. Does it violate anatomy, like boundaries? Is it going through walls? Is it something that looks like a fixed shadow on top of existing anatomy and it's not moving with the cardiac cycle? Then that could be an artifact. And get multiple views, as well as all the tricks that we mentioned to try to resolve those artifacts. So for anatomic mimickers, structures, not physics artifacts, but actual structures that can mimic cardiac masses, again, back to the same article I put in the first slide, this is a very nice summary of normal variants or congenital remnants, including webs and networks and dilated coronaries and so on, and as well as pathologic variants not related to specific cardiac masses, such as interatrial septal aneurysms, Lambel excrescences, nodules of Arantius, and of course, there are iatrogenic foreign bodies or ectopic structures that can be seen. And especially if you don't have the history of the patient, you can see things like mitral clips, for example, and you should not be confusing that for something else. So this is an example of a crista terminalis. This is an example of an LA thrombus. This is an example of an apical thrombus that in 2D looks somewhat laminated, but in 3D, it's more pedunculated. So getting multiple views is always important. This is an RA thrombus in situ that later can lead to a pulmonary embolism. Thrombi have characteristics. They can be suspicious depending on the already validated diagnosis and the echogenicity, which we have discussed, as well as the vascularity of a tumor can also help you differentiate a mass from a thrombus. This functional mechanism, mitral prosthesis here has an intravalvular thrombus. These would be the echogenic findings in infective endocarditis. They were first published by Habib et al., and a permission was taken in 2010 in the European Journal of Echo. And then this paradigm review article summarized it as vegetation characteristics: abscess, pseudoaneurysm with their pulsatility and perforation. You want to look for the color Doppler. Fistulae, look for the communication valve. Aneurysm, look for that saccular bulging of valvular tissue. And of course, dehiscence of the valve can also lead to vegetation. So if you have high risk on a TTE, but you don't see the vegetation clearly, please proceed for a TEE. Always try to see the full loops. Don't make any decisions based on short loops, like less than 1 beat or 2 beats, especially when looking for vegetation.